Hello, I'm Javier Garcia, and I want to introduce to our advanced course in mechanical ventilation. Year is going to be the 10th edition in September 15, 16, and 17th. And in this year, it's going to be special. Always 10 edition is something special, but in this year with the COVID pandemic, everything fixed because we at the beginning was thinking from the last edition to do something special for this 10th edition. So I really we want to put all together all the old participants again. So it was going to be quite a big meeting because already have passed around 250 anesthesiologists and intensivists, and really it was going to be a big meeting. So finally, through the COVID situation, we have to do it in streaming, in direct, but obviously through internet. So what we are thinking is how can we concentrate all the experience? So what we are going to do is all the theoretical lectures, instead to give it directly during the course, we are going to record all of them. And we are going to put that in our website, and we are going to send you the link so you can prepare all the theoretical material in advance before going to the course. And then we are going to let these 3 days for a webinars of 3 hours each day. In this moment, in real, alive way, we are going to perform all the workshops, all the alive workshops, all the models, just to visualize and to put in common all the concepts. At the same time, it will be the perfect opportunity to interact one each other. There are many people from long time ago, and we can see one each other again, and we can make all kind of questions. Obviously, the last day on 17th, it will be dedicated for COVID. And we are very lucky because this year our guest speaker is Professor Foti, that he is a great expert in mechanical ventilation. I'm very lucky. I had the opportunity to work with him in a national congress in Croatia. And he has been fighting from the very beginning in Italy with COVID in Monza, one of the origin of mechanical ventilation in Italy. So we are going to dedicate this last day, the whole day, to COVID, to share all the experience and mainly to clarify any question you can make us. So thank you so much for joining this year to advanced course, and we are going to go for these first lectures, that is the introduction lecture to see this physiological approach. Oh, I don't have any conflict of interest for this course because really I always feel totally free and freedom to choose the subject, the way of doing it. Obviously, my background, I have to say a few words for the ones who don't know me. I started in pediatric anesthesia and critical care, but mainly focused in pediatrics. But 10 years ago, I moved position and I gained the position of chairman of the department of Puerta de Hierro Hospital, University Hospital. It's one of the biggest here in Madrid, dedicated for adults. So I have to move to intensive care in adults and in anesthesia. If my background, what I consider is the most significant part is my passion for training in mechanical ventilation. I dedicate more than 20 years that I'm dedicated in training. I think, I'm a researcher at the same time and I publish things, but what I really enjoy is to transform this complicated world of mechanical ventilation in simple and visual concept. Because my approach is like if we go through physiology, through pulmonary physiology, and if we go through videos and simple workshops to transform complicated concept in something that everybody can understand, then we can change things. Because the story about, all about what is around mechanical ventilation is not only to publish and do it clinical randomized trials. That, of course, is the obedience and is what is the basement. But this is not enough. I have heard many key leaders' opinion all around the world that after, published 100 of papers, they say, Javier, but finally nothing changed in mechanical ventilation with the ventilator patient like the last 20 years. And I think we have to think in a different way. We have to do things in a different way to obtain different results. If we still go for the same results, like papers, theoretical approaches, nothing is going to change. We already know that after 30, 40 years of training in mechanical ventilation this way. So I think maybe we can do things in a different way. Okay, so the agenda for today is going to divide it in two parts. When I was the talk was, I mean the course was presentially. I do it in only one lecture. This is the introduction lecture, but I consider that this time is going to do it divided in two parts. So for the first part, we are going to go what is the real situation of mechanical ventilation all over the world. I'm very lucky. I can tell you through these courses that really create a great impact in different places. I've already given lectures and courses in 52 countries all around the world, from Japan and China to the States or Argentina, passed through all countries in Europe and Africa, South Africa. So I perform this kind of different way in an expert course, what we call advanced course like this one, all over the world. So I think I can tell you a real, I can tell you what is the real situation of mechanical ventilation all over the world. That is commonly the same. And the second point is, it's important to perform intraoperative lung protective ventilation. Of course, in critical care and intensive care, all the clinicians consider that protective ventilation is important. But sometimes I met in different countries, and a lot of anesthesiologists still think that this is one thing for intensive care. In my second part, or the second lecture of this introduction part, it will be to focus in what is really intraoperative ventilator-induced lung injury, and if there's any special difference comparing with the ventilator-induced lung injury in critical care. And you will see there. So if we have to master the way we create damage in the lungs, and then is after knowing that we can change and we can do protective ventilation. Okay, this is a very nice study. Not very far from here, 2017 Las Vegas study that present the real situation of mechanical ventilation all over the world, especially in the side of anesthesia. They enroll almost 10,000 patients, and as you can see here, still more than 40, 45, 50, let's say, percent of the patients still receive large tidal volumes. Even as you can see here, even more than 10, 11, 12. All these part are patients. The second is the use of PEEP. In my opinion, is is a key point to know the knowledge of service or in area about mechanical ventilation. If you don't set PEEP individually, it's because nobody have told you how to do it or how important is this. So still see how many people, let's say like around 20, 30% of anesthesiologists don't use PEEP. I think this is enough. Probably is not needed to talk more about this. If anesthesiologists don't use PEEP, really it means that the knowledge about mechanical ventilation or protective ventilation is zero. Like the PEEP they use. Zero PEEP equals zero knowledge. So, and the rest that use 5, no? The typical 5 PEEP for everybody that has been shown in some lecture from some people. I'm very sorry, both approaches are not correct. Simple things like, do you think that all our lungs are exactly the same? The answer is no. Okay, do you think like the reduction in functional residual capacity under anesthesia is going to be the same in all kinds of procedures, or is going to be the same in all kinds of patients? The answer is no. So if PEEP works to improve functional residual capacity or to avoid the reduction in functional residual capacity, can you tell me a single reason to use a fixed PEEP of 0 or a fixed PEEP of 5? Physiology always gives you the right answer. And this is definitely the most worry part. We all know now that driving pressure is one of the key stones to create damage on the lungs through mechanical ventilation. There is no doubt about that. Even the approach of mechanical power, driving power, whatever, driving pressure is always inside of these equations, and it's one of the most, if not the most important part of the equation when the patient is not spontaneously breathing, when the patient is under controlled mechanical ventilation. And we know that you create damage when you use more than 13, 14, 15. And as you can see here, more than around 50% of the patient inside of anesthesia still receive huge amount of driving pressure. Okay, what happened in intensive care? No, intensive care, they have high level knowledge of mechanical ventilation. I have heard many places things like that. So probably they do protective ventilation, everybody, in everywhere. So I love this paper, the Lung Safe Study from Bijani, who showed to us that still in distress syndrome is by far the most challenged situation to ventilate. And as you can see here, even in severe distress syndrome, in the ones who you create more damage easily with high or large tidal volumes, you can see that we still use a huge amount of tidal volume, even more than 8 and 9. So what is the consequences? And you can see here the red line as the severe, the one who should be more protective, and see how many of them still use more than famous 6 meters per kilo. Okay, and how many of intensivists routinely use recruit maneuvers to reopen the lungs and get a more homogeneous distribution of tidal volume? At best, less than 30%, and something between 9% for mild and severe 30%. That probably between you and me, this one is even less recruitable than this one. The most recruitable lungs is from anesthesia. So probably is the number should be the opposite. And prone position in only 4% or 13%. In mild is not indicated, but in moderate or severe and COVID pandemic have told us this. We have to use prone much more than we used to do it. And driving pressure. If high driving pressure is dangerous in anesthesia, imagine in distress syndrome. It's crucial to protect the lungs in this case and see how many patients still receive more than 15. That's extremely dangerous for this kind of patients. And as you can see, mortality is increasing almost linear with the driving pressure you use. So the story is there any hope to change things in mechanical ventilation? Because in both sides, intensive care, anesthesia, so far we can say it at best that 40% of the anesthesiologists and intensivists have now knowledge about protective ventilation and use it, and the rest maybe have the knowledge but don't use it. So how can we change things? I can give you I really love this new data. This data comes from the Spanish pandemic COVID-19. As you may know, Spain was one of the countries more heated. Probably the highest big wave was here in Spain. Now probably United States is getting the first position, but Spain, we really have a huge amount of patients and we are very strongly hit. So as you can see here, this is the database from the National Society of Anesthesia and Critical Care that is called COVID-19 UV care, and we put all our patients inside. This is a previous analysis with 600 patients, but now I think it's around 1,000 or 1,200 patients. And as you can see here, I was really impressed about the use of prone position. In anesthesia, the intensive care unit taken care by anesthesiologists, Spanish anesthesiologists, see how often we use prone position. In severe ones, is the red one, we reach almost 80%. Remember, in lung safe, it was less than 4%. We use 80% of our units routinely use prone position in COVID distress syndrome. And as you can see here, for example, recruit maneuver for us, in red is the same. Black is the median, red is the severe, green is the mild, and yellow is the medians distress. So, and as you can see here, the media is around 85% again. So in Spain, we are very used to individualize the use of PEEP. We recruit the patient and we go for protected ventilation based on prone position and open approach. Here you have more details. I was going through the tidal volume, and of course it can be improved, but the media was 6.9, not bad, and the consequences and the PEEP. And as you can see, they recognize at 80%, the ones who use recruit maneuvers, it was to individualize the PEEP settings. And as you can see here, the media was around 12. The ones now everybody's talking about is around 10 and 14, so something around 12, 13 is the good PEEP for this patient. But as you can see here from time to time, thanks that we individualize PEEP setting, you can see that even 7% receive even higher PEEP if it's needed. And this is for me the most proud data about the WICARE, the intensive care unit take care by anesthesiologists, Spanish anesthesiologists. And as you can see here, driving pressure. I love this data. Driving pressure was really low. Less than 12, media 12, maximum for only 14. And as you can see here in severe, media around 10. I was really impressed. I was really shocked when I saw all this data. And I say, why in Spain change is really changing? The practice. No, the theoretical. The theoretical knowledge we know all around the world. But why in Spain things have changed? And I tell you from the honestly, I mean, here maybe you know him. There was a very famous course running by Dr. Belda. He ran, now he is retired, but he ran 25 consecutive courses around 300 people every year. And I was one of his professor a long time ago, and I decided 17 years ago to start another course. So Ventimec, that is our course, our national course, now is running, instead of this course, 300 people every year pass through our courses. So if you add all the anesthesiologists who've been training through Dr. Bernard course, plus all the Spanish anesthesiologists training by Ventimec or course or national course, I can tell you it's a huge amount of anesthesiologists who really can create this critical amount of doctors in every single hospital to change the practice. So the final message, things can be changed. But I'm very sorry, not through papers, and papers. Things are going to change in mechanical ventilation if you change the way to present data. Simple and visual. Okay, so this is my message. Sometimes to keep learning in mechanical ventilation, for that sometimes it's crucial to unlearn. It's painful, but it's needed. So let's go for our approach, and I highly recommend to go in your countries to spread this way to present data. We have to go through pulmonary physiology. I always tell my resident and my staff, pulmonary physiology is not easy because it's not common sense physiology. It's in some way works totally different than you expect. So you must master, you have to study hard and fully understand it, how the lungs work in normal condition. Otherwise, you always will go wrong. If you go directly for papers without make this effort previously, that is master pulmonary physiology and master physics, especially mechanics of fluid, if you don't understand what is resistance, how can you going to really control how to manage? As simple as that. Never lose your clinical common sense. If you read something in a paper and you go to the OR or the intensive care and you perform what the author recommend and it doesn't work, it doesn't work. Clinical common sense. What you are doing in front of your patient is the final real situation. Know what some clinical trials said. Have doubt about what do you, this is important, have doubt about what you think you know. Because, for example, I can tell you, as you may, if you know me, I'm one of the patient, one of the doctor, I've been dedicated all my life around recruit maneuvers and open approach. And I can tell you what I think now, today, and after the COVID, about recruit maneuvers and PIP setting have changed totally. What I thought it was what we have to do 10 years ago. We have to change, or at least to have doubts to keep going learning. So training in mechanical ventilation really must be changed. Stop about presentation, papers. Obviously it's needed to know these papers, but it's needed that someone transform this in visual and simple images. Okay, so we finished the first question. This is the second question. How important is protective ventilation? Especially, of course, in intensive care, but in anesthesia. Are there any consequences about the way you ventilate the lungs inside of the OR? Because I'm very sorry, I've been all around the world. I can tell you that all this percentage, this 60% of anesthesiologists that don't set PEEP and don't do any special protective ventilation is because they consider this is not important. Okay, so we have to present how important is this. I really love this paper. This is a Spanish paper, one of the first to open to the world that the way you treat the lungs inside of the OR can change the mortality and the morbidity. So the first thing is PPC, postoperatory pulmonary complication. Is there any complication after general anesthesia, after mechanical ventilation? This paper show a huge amount of incidences, much more than we expect. And they showed to us from the very beginning that it was correlated with some criteria like age. If you have a patient more than 80 years old, the previous saturation, infection, anemia. He was one of the first to tell us that if you have anemia, only anemia, then you have more complications, pulmonary postoperatory complications, surgical incision, the place, and the duration of the surgery. But as you can see here, with the lowest score, you have around 10-13% of PPC. But in very high selected people, very high risk people, it can reach 1 every 2 patients. Okay, I really love this paper. Seb Paneto, he was one of the first to present to us a huge amount of patients, 3,300 patients, and they studied the mortality without any postoperatory pulmonary complication, with and without. And as you can see here, the mortality, if you don't have any pulmonary complication, generally speaking in general anesthesia, general surgery, is only 1.4. But it can reach and increase up to 20% if you have only one postoperatory pulmonary complication. And of course, increase the mean time, the stay in the hospital, and of course the cost, and create a lot of problems. So, first of all, the way you treat the lungs inside of the OR with other risk factors are going to create postoperatory pulmonary complications. Second, to have postoperatory pulmonary complication is important because increased morbidity, increased cost, and even increased mortality. In this study, they analyzed separately abdominal surgery with thoracic surgery. See how important is this problem in thoracic surgery. In thoracic surgery, if you don't have any PPC, mortality is the same, 1.4. If you have only one pneumonia, pneumothorax, reintubation, any of those, you increase mortality almost up to 36%. So 36% times more. Okay, so important thing, the way we present data should be, and do training in mechanical ventilation should be different. Second, the way you treat the lungs in intensive care, of course, but even in anesthesia matters, and matters a lot, because you create postoperatory pulmonary complications, and then you increase morbidity and even mortality. So PPC increased mortality, increased morbidity, and is in no sense health cost. For example, I do this calculation for my course, for my hospital, and as you can see here, you have a pneumonia in the postoperatory period of a cholecystectomy, only 15 days with antibiotics in the floor, not an intensive care, it will be even worse. You see what it means, 9,000 euros. If you multiply by the incidence, it's only 10% of the number of surgeries all around the world. See what it can be the cost, 207 billion euros. Okay, so can we do something to reduce, this was the next question, postoperatory pulmonary complication? As we said, let's ask physiology. So here we have, this is a very, very nice study from Professor Gary Niemann. He, for the very first time, they put a microscope in the surface of a window in a thorax in a pig. So it's for the very first time we all can see how a pig breathes spontaneously directly, the way they do it. This is the surface of the lungs. And as you can see here, I want you to fix how we are not designed to change the size of the alveoli. This is a group of alveoli called acinos, and the size between inspiration and expiration is almost the same. So there is no a single atelectasis. This is the first thing I want you to fix. There is no atelectasis when you are spontaneously breathing, physiology speaking. So that, thanks that you don't have atelectasis, the tidal volume, that is tiny tidal volume, is perfectly well homogeneously distributed. If you reduce the surface of the group of acinics that is collapsed, the rest have to double the size. So one important concept, and this is one thing that really is totally different that I've been taught. If you have collapse, of course you have a teletrauma cyclic open procedures that itself, it hurts a lot. One important thing, cyclic overdistension come from atelectasis. Just the opposite that we need to know. Overdistension is high PEEP, recruit maneuvers, whatever. I'm very sorry. If you have collapse, the rest of the alveoli who are open have to receive double volume, double, and this is cyclic overdistension. So even to prevent overdistension is through to reopen the lungs. So lungs are designed to receive an homogeneous, this is the key concept, homogeneous, well-distributed, low tidal volume. If you have an increase in the oxygen demand, the physiological response, and neonates teach you this, is to increase respiratory rate. Just what neonates always do. We are not designed to have atelectasis. Any normal, healthy person breathe without atelectasis. If you have a big amount of atelectasis, sooner or later you're going to have respiratory problems. We are not designed to have cyclic collapse, and we are not designed to have cyclic overdistension. Okay, let's continue. So please fix these ideas, these images, videos, for the rest of your life. Everybody loves homogeneity in mechanical ventilation. This is the way we breathe, and this is the same peak after intubation and without PEEP. And as you can see here, if you don't set PEEP, the minimum amount to keep the lungs open, see what's happened during expiration. These two alveoli collapse during expiration. What are the consequences? You are seeing for the very first time probably atelic trauma. Open, close, open, close, open, close, open, close. This phenomenon creates damage in this area. But the problem is not only for the ones who goes for collapse during expiration. The problem is for the whole lungs, because the ones who don't go for collapse because they are more stable, see what's happened. They have to double the size. You see, this is the called over distension, cyclic over stress, cyclic over distension. So the whole lung is going to suffer through the ones who are still open by over distension, and the ones who are go for collapse because open close phenomenon. So please, we are not designed to have atelectasis. I'm very sorry, nobody can say anything. You don't need a clinical randomized trial to say that. You have to master physiology. That's the point. So if you master physiology, you perfectly know that the way the lungs works is fully opened, not even in the back part, no atelectasis anywhere, and we have a low tidal volume well distributed. Whenever you don't recruit the lungs and don't set the minimum PEEP to keep the lungs open, you create double damage, atelic trauma and overdistension. Okay, for the ones who say, okay, how important is this, Javier? This is a very nice study from my friend Carlos Ferrando, and as you can see here, they perform a CT scan in the recovery room. I think in those days it still allowed them to do it, not anymore. And as you can see here, he fixed with CT scan that up to 36% of any patient in a general PACU have atelectasis. And this atelectasis remains in the patient until he starts to walk, 2-3 days. And this is one of the main reasons to create postoperatory pulmonary complications. And the story is like if the patient has a small hypoxemia, the only thing we do is to give oxygen therapy, oxygen, and this is not the way to solve the situation. So far, is the only objective to avoid hypoxemia is increase VO2. This is not the way to reopen the lungs. So this is the crude reality. So let's pass or the final part of this for this lecture. It says protected ventilation and anesthesia. Okay, for the ones who still think that, okay, Javier, this is not important. I run healthy patients, daily cases, 1-2 hours of mechanical ventilation. This cannot be important. Okay, I really love this research. The ones who know me, I've been dedicated, I'm a clinician, but I really love research at the lab because really you can explore areas that you cannot do in a clinical randomized trial. So this is a very nice study from one of the fathers of pulmonary physiology, Dreyfus, and he was one of the first to show us that if this is rats that was ventilated, this is normal, and then after the mechanical ventilation, they extract the lungs, they weight the lungs to see the edema and the damage, and they cut them and analyze like anatomopathology exams. And as you can see here, only after 5 minutes, this is a very aggressive ventilation with a driving pressure of 30. So only in 5 minutes of very severe, extremely aggressive ventilation, you can see some areas of damage. But in only 20 minutes mechanical ventilation time with a very aggressive driving pressure, see the results. The analysis of these lungs, it was exactly the same like a distress syndrome. This is what is called VILI, ventilator-induced lung injury. The way you can create and destroy fully the lungs of the patient, even the patient are normal. So they say, okay, Javier, but this is rats, so people don't like experimental research. In my opinion, it's crucial for really breakthroughs. So let's see what's happening in humans. So if you want to know what is the right tidal volume, why don't we go for papers and see what is the minimum that is being published to use and the maximum. So the minimum use is high frequency oscillatory ventilation. They only use dead space, 2-3 meters per kilo. And the maximum published so far to create a damage is 32 meters per kilo. You say, wow, Javier, oh, this is incredible, impossible in patients. Okay, let's see. So the media is 15. So probably not in your because you are doing this course, so you are the ones who really master protected ventilation in your hospitals. But let's see all their colleagues, no? 12, 13, 15 is not a long time ago using tidal volume. But even if you go for 2004 now, thanks God have changed. But for example, the ESA guidelines of 2004 recommend for one lung ventilation in thoracic surgery when they go for hypoxemia to increase tidal volume up to 15. Okay, so if you have two lungs, and you are delivering 15 between the two of them, okay, this is too much and you create damage. But imagine if you go for one lung ventilation and you collapse one lung, and still you are setting 15 minutes per kilo. How much tidal volume are you using this one? Double, 30 milliliters per kilo, the same that you use in rats. That's why I really recommend to go for this paper that really shocked my mind when I saw it. This is a paper done by radiologists, so nothing to do with intensivists, anesthetists, radiologists, that they were very strange that in a certain moment in 6 months consecutive, they record 12 cases of distress syndrome after thoracic surgery. So they report this to the anesthesia department, say what's happening here. Our anesthesia department talk with the thoracic service, and they say, no, this may be the surgeon that is cutting the lung and touching the lung and scratching the lungs. Yeah, the answer is, I'm very sorry. The one who keeps healthy in the post-operatory period is the one that's been cutted and has been operated on. As you can see here you have the drains. So the only lungs who was damaged is the one who was ventilated inside of the OR. So in only 1 hour, 1 hour and a half of aggressive one lung ventilation with these ASA guidelines of 50 meters per kilo, because if you increase tidal volume, you see that the saturation goes up. And then the problem is solved in front of you. But you create a second problem that finally kills the patient. That is a distress syndrome in the post-operatory period. Remember the mortality rate. No PPC, 1%. 1 PPC, like this one, 36% of mortality. So this is my final message. Mechanical ventilation, I totally agree with Makun, an editorial in critical care, that I think all the doctors, the physicians should be, and nurses should be really have this phrase in front of the. In my opinion, this is for the advice for all the companies who produce ventilator. This should be put in front of any ventilator. Mechanical ventilation is a massive destructive weapon of a most powerful tool for freedom. So the story is, it depends on what. It depends on how clinicians use it. If you use it in a protective way, you don't create villi, you don't create more mortality, more mortality. Otherwise, you are going to create a huge problem. Okay, so this is to hear the first part. Thank you for following us, and let's see, and let's